Welcome, everybody. Welcome to another episode of PEM Rules, the Pediatric Emergency Medicine podcast. I'm your host, Yaron Ivan, as usual. And today I have a discussion with Sophia Wang, a PEM Fellow who some of you may know. She's been with us in the past. Sophia would like to discuss with us how she applied some of the PEM rules to some of her patients and how valuable they were. So welcome, Sophia, back to the show. Sophia, I don't think you need much of an introduction because you've been with us on the show before. I'll briefly say that Sophia Wang is a PEM Fellow in Mississippi who has been on the show in the past. You can check out episode 64 from June 5th if you want to check it out. Today, she's here to tell us how she applied PEM rule number 9, which I'm not going to say what it is. I'm going to let you say that, Sophia, in her clinical work. So thank you, Sophia, for coming back. What do you have to tell us?
Hi, I'm excited to be back here again to talk about my experience. And today, what I really would like to talk about is PEM rule number 9, one of my favorite rules in general in pediatrics. The single most important indicator of a healthy baby is weight gain. And my first experience with this was actually before I even went to med school. When I was a Peace Corps volunteer, I was in Nicaragua, and the city I lived in had a health post essentially, or like a health center. And the nurses and the staff there would go out to the rural communities every day, a different rural community every day, to provide medical care to the folks there. And one of my big tasks and favorite one was I would get to pick up the baby and hold them and then put them in this little sling that's connected to a scale and help the team weigh the babies. And we would chart the baby's weight on a growth curve. And this in like rural areas of Central America would tell us a lot about how the family was doing overall and if they would need more resources or anything like that. For the most part, our American babies grow very well since usually we have a good supply of formula supplementation if mom isn't able to breastfeed. So in a way, it's even more concerning if a baby here isn't gaining weight well. So when their weight isn't where it should be, there's a good chance that there's an underlying medical issue going on then, and it's not just a matter of nutrition and food supply.
Very interesting story. I completely agree. I do believe, Sophia, that even in the US, unfortunately, most cases of failure to thrive are due to simple inadequate caloric intake and not secondary to a systemic disease, but that obviously is a diagnosis of exclusion. So we always have to keep in mind rule number 1, it's not the patient's job to prove that they're sick. It's your job to prove that they're not. I completely agree. I'm happy to hear that PEM rules number 9 and other PEM rules apply everywhere in the world. I'm curious to know what else is coming, the rest of the story.
So what we saw here a few months ago in Mississippi was we had a 60-day-old full-term baby who got sent to the ER by their PCP because their pediatrician noticed an increasing head circumference from 30% to 90% over the course of a 4-week period. The baby didn't have any other symptoms. The fontanelle was large, but soft and flat. And when I asked mom, like, does it seem like larger or different than usual? She said it's always been like that. The baby's vital signs were normal, was feeding well, alert, and acting just like a happy 2-month-old. We got a CT scan to address the PCP's concerns, and this baby's CT scan showed severe ventriculomegaly with cyst. So we got neurosurgery to do a ventricular tap, and it actually showed GBS ventriculitis, even though the only blood work indicator that something was concerning was an ANC of 5,900. So outside of the standard 2,000 to 4,000. Only other red flag the baby did have was poor weight gain. So she was born at 44th percentile. And then when she arrived to the ED at 2 months of age, she was down to 0.5 percentile. And this was probably the only other sign, very subtly, that something sinister was going on. Like, she's been feeding well, so why isn't she gaining weight? And most likely it was that her nutrition was just not all going to her body. A lot of it was going to the infection in her brain. And cases like this makes us realize why we have such a low threshold to work up and treat neonatal meningitis. They really can present with very few symptoms, both clinically and on the lab workup. And she had a weight change before she displayed any other symptoms of illness. And so this baby has an excellent PCP, very lucky that her parents chose him to be her doctor. And he was very observant, looking at the growth chart. And even though she overall just looked very well appearing to us, he picked up on something very subtle and very likely saved her from a worse outcome.
That's really an amazing story. Great job, Sophia. Truly speaks to the value of this rule and the importance of opening your mind. Not every meningitis presents with fever, vomiting, etc. Just some rules, PEM rules that come to mind based on the story is rule number 11, newborns are black boxes. Be conservative as you can and do as many tests as you need. That's a great story that truly demonstrates that rule. You would think about meningitis in a very specific way, not that. And rule number 69, which is kind of similar in this situation, rules are meant to be broken. Not every patient presents like we learn in the books. Some kids with appendicitis have a left lower quadrant pain, etc. So really great story. What else do you think you learned from the story?
So I think another important rule that I learned from this case is to address the PCP's concerns. And it's a lot of times PCP may know information about the patient or about the family that we're not able to discern during a short ED visit. So for one, they have more growth chart information, including the head circumference that we don't do in the ER. They may also know family history that the family doesn't realize is important to tell us. And in many cases, the PCP may have different management practices and want to obtain workup that a lot of times I feel like is not necessary. But just kind of similar to how we sometimes obtain labs and imaging workup, within reason, of course, if a parent needs it for reassurance, we should, to a certain degree, extend that courtesy to the PCP as well. Everyone's allowed to practice medicine a little bit differently. And it also doesn't help anybody if the PCP and the ER just keep bouncing the patient back and forth. The PCP thinks this needs workup, send them back to the ER. The ER is like, we don't need workup, send them back to the PCP. And it's just a difficult situation for the family then. And I've actually had this similar experience regarding babies who have hyperbiliary in the past when I was a younger resident. It was in regard to a baby whose bilirubin level didn't quite meet the phototherapy threshold. And at the time, I was like, I am going to practice evidence-based medicine. I will stand by evidence-based medicine. We're not going to give phototherapy if it's not at threshold. We're going to recheck the billy outpatient the next day per the guidelines saying you can check within 24 to 72 hours if it's in the high intermediate risk region. And my attending at the time pointed out that if we just send this patient back to a PCP, most likely the billy is still going to be high, but not at the phototherapy threshold. So then the PCP will just send them back to us. So you can either keep this baby in the hospital for days just to check the billy. Your other choice is to just bounce them back and forth between two doctors who disagree on management. Or you can just put the baby under billy lights. It's low risk, low side effect, like virtually no side effects that we know of, and lower the billy to a point where the PCP just won't feel like they need to send them back. And we chose that third option at the end of the day. And I think in cases like this, it's also fair sometimes to call the PCP if it's during like daytime reasonable hours, just to ask what their reasoning and plan is and see if we can reach an agreement. Saying like, oh, like maybe when you saw them, their clinical status was this. And now I see them that their clinical status is a lot better. So do you truly think we need to do this workup still? And then other times, a PCP might actually reveal information that's very relevant, such as if like a cousin has a G6PD deficiency, or if like the parents just aren't reliable at feeding an infant overnight, or something else going on that we weren't able to get during the visit. It may just end up that we conclude we have different management practices and try to come to an agreement.
So those are, again, excellent points, some really great points. And, we're all here for the patients. And I agree with you, Sophia, that direct communication is always, always preferable. Those of you who haven't, I recommend listen to episode 59 from March 27th, which is where I discuss some of those exact issues with a primary care friend of mine in Colorado. The relationship between the primary care and the ED physician is very, very important to patient care. Easier said than done. We've all been in that situation where what the primary care is worried about seems trivial to us. So I agree with you. Calling the primary care and discussing it with them for the sake of patient care is sometimes preferable. I agree 100%.
Yeah. So my conclusion from this case, from what I learned with this experience, is number one, always pay attention to the growth chart. We don't measure the FOC in the ED, but the weight trend can tell you how well taken care of a child is, especially if it's a medically complex child. It can also tell us how well managed the underlying conditions are. And in infants that are otherwise normal and well, it may be the first sign of an underlying medical problem. It may just be that the parents aren't feeding as much as they're telling us they are, but we don't want it to be something more underlying that needs more sinister that needs to be addressed right away. And number two, always take the PCP's concerns seriously. The PCP a lot of times does know the patient and the family better than the ER doctors do. And if it does end up just being different opinions on medical manage, we should try to reach an agreement to do what's best for the patient.
Those are, again, excellent points. Couldn't agree more. Great job, Sophia. Thank you very, very much for sharing that incredible story. I think this is definitely a story we all can benefit from. I agree with you. Many, I would venture to guess, most primary cares know their patients very well. They know the parents very well, and they can see a lot of things that we kind of ignore. We literally don't have the time to see because our interaction with the patients is so brief. So, yeah, taking the primary care's concern is certainly a very good advice. Great job, Sophia. Thank you very, very much for coming on the show for the second time. I also heard that today is actually your birthday. Is that right?
Yes, it is.
So happy birthday. And thank you so much for dedicating your time on this special day to come on the show and talk to us. I hope the rest of the day goes great and you have some serious celebrations.
For sure. For sure. Thank you.
Thank you very much, Sophia. We'll hopefully see you next time.
See you soon.
And that's it for today, guys. Thank you very much for listening. I appreciate it. Please continue to check out PEM Rules and write to me any feedback you have. If you want to come on the show like Sophia and discuss your experiences, I would love to hear that. Thank you again, Sophia, for coming on the show on your birthday. This outro is especially for you for the obvious reasons. Have a good day, everybody.